Hi, I'm Jacob Langer. I'm a pediatric surgeon at the Hospital for Sick Children in Toronto.
I'm Alan Goldstein. I'm a pediatric surgeon at Mass General Hospital for Children.
Jason Fisher, and I'm a pediatric surgeon at Cincinnati Children's Hospital.
Hi, I'm Dr. Luis de la Torre. I am a pediatric surgeon at Colorado Children's Hospital. Hi, everyone. Currently, most of the surgeons in the United States are doing primary pull-through for patients that are born with rectosigmoid aganglionosis. So, how do you manage a patient, a newborn patient with Hirschsprung disease affecting the rectosigmoid area in order to do a primary pull-through? Jason, how do you manage these patients?
Sure. Once we have our histologic diagnosis and we've resuscitated the patient, we make it very important that we teach the families how to do rectal irrigations prior to doing our pull-through for the preparation if that is needed post-operatively. So we make sure we teach the family how to do rectal irrigations. And then if the radiographic imaging alludes to a rectosigmoid type transition zone, the patient's able to be controlled or is stabilized with rectal irrigations, then we will do a primary pull-through during the neonatal stage when we can get operative time, usually in the first week or two of life. We typically do that laparoscopically, assisted with a transanal component, and we've had pretty good outcomes with that. So I don't know if others have different opinions.
Thank you, Jason. Jack.
Yeah, we do pretty much exactly what Jason said. I think it's important to make sure that the child is well decompressed. I tend to use an umbilical incision rather than laparoscopy, but I think the important point is to identify the transition zone histologically before you start the transanal dissection, because the radiology, the contrast enema, is not always accurate in telling you where that transition zone is. The other thing that some people do is wait until the child is a couple of months old. Some people use 4 or 5 kilograms as the size at which they're willing to do a pull-through. I tend to do it as soon as we make the diagnosis and get time in the operating room, but I think it's also reasonable to wait a little bit longer, as some people do, as long as the child is well decompressed and as long as the parents are comfortable doing that decompression. The risk of waiting is that the child may get enterocolitis while you're waiting, and they can get pretty sick.
Thank you, Jack. Alan?
I agree with what both Jason and Jack have said. It is my preference to wait a couple of months. That is with the caveat that the irrigations have to be effective and the baby is adequately decompressed. And if they're not, then certainly to proceed with the pull-through earlier. I also start laparoscopically. Obviously, as Jack said, getting the level, figuring out where the ganglion cells are is key before starting the transanal part. I also think that doing the laparoscopic resection of the division of the mesentery is very important, because when you do it laparoscopically, it can minimize how much stretching of the anus you need to do it from below, which potentially reduces post-op sphincter injury. That's the way I would approach it.
Thank you, Alan. So in summary, we can say that one of the most important procedures before we do a primary pull-through is the rectal irrigations. So everybody agrees that all the pediatric surgeons and the team in the hospital, they should be very familiar with these procedures. It's one of the most important goals in patients that we want to do a primary pull-through. How to do rectal irrigation is one of the most important conclusions. The second one is some surgeons prefer to do the pull-through early, first week, 2 weeks of age. Some surgeons prefer to wait probably 1 or 2 months, so the patient is at home with irrigations, eating, gaining weight, and then come back to the hospital for the pull-through when the patient is 2 or 3 months of age. Any other comment about this point? Thank you very much, all of you.